All right, we're going to be talking about Chapter 14, Incontinence. So what is incontinence? Well, it's the involuntary passage of urine, which is urinary incontinence, or feces, which is fecal incontinence. Now, the prevalence and costs of incontinence is very high, and that's because there's the cost of patients having to have briefs, pads, maybe surgery, skin breakdown, urinary tract infections. All of those factors not only prolong the stay of the patient in the facilities, but it also raises the cost. So urinary continence is important, and the prevention of that. Now, physiology of urination, I'd like to talk about that because there's some of my favorite words here, and that's micturition. What a great word. That means urination. So micturition, urination, and voiding all mean the same thing. They're normally controlled by a healthy bladder and a muscle. There's an open urethra, and there's normal transmission of nerve impulses and mental alertness. Now, normally urine drains from the kidneys to the bladder, and it's stored there until it's eliminated, and the bladder can usually store about 200 to 250 mLs of urine. And then messages are sent to the brain saying, hey, you need to go to the bathroom, and the patient becomes aware of bladder fullness and the need to void. Now, there's problems, though, that come along. But we need to find out what are the diagnostic tests and procedures. Well, there's the urodynamic procedure or neuromuscular function. So the urodynamic procedure, which is important to know, assesses the neuromuscular function of the lower urinary tract. These procedures include uroflowometer, which measures voiding duration and the amount and rate of urine voided. So those are important to know, and that's on page 216, 217. You can probably hear me turning my pages, so if you follow along with me. Also, there's the post-void residual, or PVR, which is the volume or amount of urine remaining in the bladder after voiding. So that's, so you voided. So post-void or after you voided, how much is left in your bladder? Well, hopefully nothing, but if it needs to be measured, they would do a PVR, post-void residual, and they can do that in a couple ways. They could do, first of all, you have the patient void. After they voided, they call you and let you know, I just voided, and that's when you can check the residual right after they've voided. So they'll call you on the call light. The doctor will have ordered this, and then you will either take a ultrasound and measure. Some facilities have ultrasounds just for the bladder, and it's really cool because the machine, it's like an ultrasound, so it has a little rounded edge, and you put the ointment on right on top of the bladder, and then you rub the ultrasound machine across there, and you can see like a little yellow island if there's any urine in there. So they can measure it that way, or they can catheterize the patient. Of course, that's more invasive, more risky, so it's really better to have the non-invasive portable ultrasound machine available. So what are some therapeutic measures for urinary incontinence? They can be behavioral, pharmacologic, or surgical. Behavioral interventions involve bladder training, and that's where the patient needs to be educated and needs to be on a scheduled toileting, and they need a lot of positive reinforcement, kind of like, I hate to say this, but it's similar to when you're training your children to go to the potty instead of being in a diaper. So you encourage them, give them a lot of positive reinforcement, and you try to encourage voiding every 2 to 3 hours while awake. And that's bladder training. So you're training the bladder to hold it for 2 to 3 hours while they're awake. Now, while they're asleep, of course, they make less urine. Everything kind of slows down. So usually a person gets up in the morning and urinates right away, right? Sometimes they have to get up in the nighttime, but if you stop drinking fluids around 7 o'clock at night, you usually shouldn't have to urinate, maybe just before you go to bed and then when you wake up. Now, the next thing is habit training, and that's also called timed voiding. And that's where you train the patient to void at scheduled intervals. And again, that may be every couple hours. But the way that you find out their schedule is they need to keep a diary. And then you find out what's their habit, what's their normal way of going to the bathroom. And then you try to keep them held to that habit. Another one is prompted voiding, and that's used with people who are dependent or cognitively impaired. So the caregiver checks the patient for wetness at regular intervals and asks the patient whether they feel wet or dry. The caregiver then encourages the patient to try to use the toilet, and then of course prays for the patient trying to use the toilet and remaining dry. And this process is intended to help the patient recognize their ability to feel the signal to void and to hold the urine, maintain continence, and to ask or accept assistance from caregivers for toileting. And that's usually about every 2 to 3 hours as well. Then we can have the pelvic muscle rehab. I want you to look on page 218 at the patient teaching box, and that's the instructions for pelvic muscle or Kegel exercises. And this is pelvic muscle rehab. This is uncontrolled loss of urine is commonly caused by a weakness in the perineal muscles that normally control urination. So you need to strengthen those muscles. Now this can be caused from, having children, just aging. So to improve muscle strength and endurance, there's 2 types of exercises. Short exercise, which lasts about 2 to 5 seconds. Firm contraction, so you kind of squeeze your buttocks muscles together and hold. And this is, the short time is 2 to 5 seconds. Normal is about the long contractions, and that's, I like to call it, and you will remember it much more easily, by the 10-10 rule. That's hold 10 seconds and relax for 10 seconds, and then hold for 10 seconds, tight, 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 and relax for 10 seconds. And that's the Kegel or pelvic muscle exercise. Now, in the book it says 6 to 10 seconds, but 10 is right in there, right? So 10-10 is a lot easier to remember. Another thing that you could use is biofeedback, electrical stimulation of the muscles of the pelvic floor. Vaginal weights, I don't like that too much. May be used with pelvic muscle training in women. They don't use that very often. Urge suppression is used to gain control of the bladder to prevent leakage. When a bladder urge is felt, the natural tendency is to rush to the bathroom, to void, or leave your class because your teacher's boring, right? This action tends to make the bladder more unstable and likely to leak urine. So by interrupting the bladder urge and gaining control, so not the minute that you feel that urge, You suppress the urge and let it pass. Now, I'm not trying to encourage you to get a UTI, but this is, and I'm not talking really to you, I'm talking about our patients, right? So we want to, when they have the strong urge to void, stop what they're doing, sit down, stand quietly. Quickly tighten the pelvic floor muscles like the Kegel type squeezing. Breathe slowly in and out while contracting the pelvic floor muscles. Visualize suppressing the urge to void. Wait until the urge passes, and it will. And then while continuing to squeeze the pelvic floor muscles, walk to the bathroom. Can you imagine that walk? It's like a little waddle trying to hold that in. But anyway, that's called urge suppression. All right, what's some drug therapy? Well, on page 219, it lists some drug therapy. There's uricoline. You may recognize some of these medications. Maybe you've passed them, or you're going to be learning about them in pharmacology. So uricoline, the use is for overflow incontinence. Now, I'm not requesting that you remember all of these meds, but just know that they're here on this page, and know that you will be learning about them in pharm. But we want to become familiar with these words. So this was a cholinergic med, the uricoline. Then we have the anticholinergic med. It actually blocks a receptor. Ditropan would be one, and it's used for urge incontinence. So one, you've got overflow incontinence, where you've got an atonic bladder. That's where you just can't really feel that urgency, that innervation. Then there's, like I said, the urge incontinence, ditroban, or Detrol is another one you may hear or see at the facilities. You've got an alpha-adrenergic medication, Cymbalta. I think you've even seen that on TV. That's for stress incontinence. Then there's some alpha-adrenergic agonist blockers. That's a mouthful. Cardura, Hytrin, Flomax. I love that one because that tells you exactly what it does. Flow, maximum flow. It's for overflow incontinence. You've got bulking agents. That's more collagen for bulking, for stress incontinence. And then there's alpha reductase inhibitors, Proscar. Now, those are all medications used for urinary incontinence, but notice the nursing interventions and the side effects. Quite a few side effects. So, you know, if you can control it by doing another method that I've mentioned before, the urge suppression or the bladder training, habit training, prompted voiding, it's much better than putting them on a medicine that may affect their heart or other CNS type depressants. We've got nonsteroidal anti-inflammatories mentioned here, tricyclic antidepressant agents, estrogen. You don't want to put your patients on things like that if they don't need it. So be aware. Nothing on the test about meds, really. On the other page, there's a few mentioned also, the tricyclic antidepressants. Elavil would be one. Let's go to urine collection devices. So there's external devices, and those should be considered as an alternative to indwelling ureteral catheter in patients without urine retention or bladder outlet obstruction. So the external urine collection devices are useful for men who do not have retention or bladder outlet obstruction. And I think maybe you learned how to put one of those on, but condom catheters. They do have condom type catheters for women, but they're not as easily used. And they don't fit over, of course, they're more like a receptacle. So we've got the condom cath for the man. And be sure that if you do use that, you don't tape it too tight to cut off any circulation. Intermittent self-catheterization. So some people can actually catheterize themselves. They have kits that they can keep in their purse or their pocket. It's not exactly a sterile technique. It's more like a clean technique. Aseptic type technique, but people live with it, and they catheterize themselves, and then it's just disposable. So, and this is on page 220 under external intermittent self-catheterization, sorry. If more than 500 mL of urine is obtained, the time interval is shortened. So like if you go on a every 2 to 3 hours self-catheterization, or maybe you try to go every 4 hours because you're out and about, you try to hold it for 4 hours. But if you see that's not working, you might have to shorten the time, or you might have to lengthen the time, just depending on your particular needs. Then, of course, garments and pads for incontinence. If you walk into Target, you can go down the aisle where all the pads and the panties, the pull-ons, the pull-ups for adults are. They're a lot thinner now. They're not so bulky like they used to be. The ones we use at the facilities, I believe, are more bulky. But, you know, if you're just running errands and you need to wear a pad or a garment, you just use something thin, but it's like a pull-up, just not bulky. Because really there's a big stigma against, or even admitting that you have leakage. So there's a picture on page 221 that shows light to moderate urine loss and the different types of briefs and guards and pads that you can use. So as I was saying, there's like a stigma about urinating, and of course the biggest fear, I think, would be the smell. So you don't want to smell, so you want to change those pads as soon as you can, not wear them forever. There's a penile compression device or a penile clamp that's applied to the penis to compress the urethra and prevent the passage of urine. So sometimes a small amount of leakage may persist, requiring a pad to protect the clothing. You need to prevent neurologic and circulatory damage or impairment or injury if you use the clamp. So it needs to be repositioned frequently. And it is controversial for obvious reasons because it can cut off the flow. And I don't mean the urine flow, I mean the blood flow. All right, so let's go to pelvic organ support devices. See if that's on the next page here. So pessary. I don't know if you've seen one of these or had a patient with one. It kind of looks like a donut, and it just fits up in there to support the pelvic organ. It was used a while ago. It's not used quite as much anymore, but you still may come across it. It's a device similar to a diaphragm that's inserted into the vagina that lifts and holds the pelvic organs into place. It may be used to treat stress incontinence in women with relaxation and prolapse of the pelvic structures. So the important thing you guys need to remember here about a pessary is it does need to be removed periodically and cleansed. You need to clean it. So it can be removed, cleansed, and replaced, and you need to document that. Document that what day you did it, what time you did it, how did it look, or document how the patient tolerated it. So that's something you need to be sure and do. Another thing is the bladder neck support prosthesis that can be used as well. Sometimes that's helpful for some people. So I'm giving you a lot of options that people can choose or that different people need so that you can be aware. Now there is surgical treatment as well. The book doesn't go into this as much as I did on the slide, just because I want you to be aware. Knowledge is power. So in surgical procedures, they may have to remove obstructions if that's what's causing the problem of incontinence. Maybe it's a stone. Treat severe detrusor overactivity. So that detrusor muscle is the pelvic muscle. Implant an artificial sphincter. That prevents leakage. Reposition the sphincter unit. Improve perineal support. So like a sling would be an example of that. Inject substances that increase urethral compression. So like suburethral bulking agents is an example. Okay, implantation of electrodes, that can be done. So those electrodes stimulate the contraction of the muscle. Retropubic urethroplexies and pubovaginal slings, artificial sphincters. So those are possible surgical options. Urologist would be the one who would do that. So what are some types of urinary incontinence? Well, there's stress incontinence. Stress incontinence is the involuntary loss of small amounts of urine during physical activity that increase abdominal pressure. So coughing, laughing, sneezing, and lifting are examples of activities that often result in urine loss. In women, stress incontinence is usually caused by relaxation of the pelvic floor muscles and the ureteral vesicle junction as a result of pregnancy, childbirth, obesity, and aging. Sometimes there's urethral trauma, and that can be from abuse. It can also be horseback riding, can cause things, urethral injury, especially in women. I don't think it mentions that in the book, but it is a possibility. Mixed incontinence, so you've got the stress incontinence, the urge incontinence. Urge incontinence is the involuntary loss of urine associated with a strong, sudden urge to void. So can you see the difference of stress? Stress incontinence is where you laugh, or some stress has caused the pelvic floor to weaken. So that would be laughing, coughing, sneezing. And then the urge incontinence is the involuntary loss of urine with a strong, sudden urge to void. So you have that urge to go. There's a mixed incontinence. There's mixed bag of incontinences. There's overflow incontinence and a functional incontinence. Of course, that would be if you have some sort of functional problem. Okay. So in the overflow incontinence, it's an involuntary loss of urine associated with overdistended bladder. Small amounts of urine are expelled from the overfilled bladder during episodes of increased intra-abdominal pressure. So this can be a problem if you don't go, because it can build up, go up into the ureters, and then cause kidney damage as well. Also, neurogenic bladder is a bladder dysfunction caused by neurologic dysfunction associated with the spinal cord injury. That's a neurogenic bladder. That's under the overflow incontinence. Now, in the management of the overflow incontinence, it does mention a few medications on page 225. Uricoline is mentioned there, and mini press is mentioned there. Now, you may have remembered mini press from either your hypertension or your cardiac drugs. So you know these drugs do affect other things. They're not specific because those side effects could affect other parts of their body. All right, keeping on page 225, we're going to talk about the Crede method. That's a technique used to empty the bladder. It involves using that open hand to press on the abdomen over the bladder to promote urine passage. So that may be used. But now here's something that you guys, I can't remember if we learned this in neuro, if we've had it yet, but it's going to come up. You're going to see it again. So it's not that you have to remember it right now. It's just that I really want you to remember it in general for the future and for taking care of patients. This might come up before you even get to learn about it. So I want to talk about it because it's really important, because it's dangerous. That's why. So for patients who have incontinence because of neurological problems, bladder drainage must be maintained. There's an exclamation mark after that. Bladder overdistension may trigger a serious reaction called autonomic dysreflexia, in which the blood pressure rises to life-threatening levels. This can be prevented by emptying the bladder often enough to prevent overdistension. So that's something that is going to show up. That could show up on NCLEX. It could show up again later on as we get into Med-Surg 2 and we learn about different types of problems. But right now, just know that that is a complication. Autonomic dysreflexia. They get a really, really high blood pressure. It can be life-threatening. Okay, let's go to functional incontinence. Functional incontinence is the term used when a person is incontinent because of an inability to get to the toilet as a result of physical or cognitive impairment. Or maybe there's things in their way. They can't get there in time. Some people wait till the last minute, and then when it's time to get there, they can't get there in time. So these people need to be close to the bathroom. If they have functional incontinence, they need to have the bed close to the bathroom so they can get there in time. Really important. So in order to get them there in time, they might need a wheelchair, a walker, bedside commode, maybe because they can't get to the bathroom in time by themselves, a urinal at the bedside, grab bars in the bathroom are all important. So the nursing care of the patient with urinary incontinence, and I'm having you refer also to box 14.4. Oh, that's 14.3, sorry. That's screening questions for patients with incontinence. So I want you to take a peek at that. But I want to go back to the nursing care of the patient with urinary incontinence. So why are they here? The presence of urinary incontinence is determined based on their history, their physical, and various diagnostic tests and procedures. Determine the patient's concerns about their incontinence. And you know, it's not always easy to talk about. So they may be hesitant to talk about it. But we need to just talk like it's, you know, a normal thing that we talk about. Their present and past health, their medical history. Now, notice I have here their present and past history. Are they diabetic? Because we know urinary issues come along with diabetes. And so do a lot of other issues, because diabetes affects every organ in our body. So, of course, it affects the kidneys and the bladder. So, do they have a history of diabetes? Let's do a review of their systems. What have they done to help themselves? You want to be sure and find out if they've kept a diary, if they have a pattern, what their bowel pattern is as well. That past medical history on page 226 is where it talks about the diabetes. That's important to know about their history. A review of their systems. Do they have arthritis in their hands? Maybe it's difficult to see, difficult to get their clothes off so that they can get to the bathroom. You want to measure their vital signs and their height and their weight. Be alert for fever, tachycardia, edema, and weight gain, because that weight gain could be the retaining fluid for some reason. Maybe they're not urinating. Sometimes incontinence is first recognized when an odor of urine is detected during the exam or when providing care. So palpate the abdomen for masses, tenderness, fullness, or distension. A distended bladder or abdominal distension associated with constipation is an important finding. And then that functional assessment, you want to find out their usual activities and habits, what could be contributing to their problem of incontinence. Are they close to the bathroom? How's their hygiene? Again, the book refers you to box 14.4, which is a focused assessment of patients with urinary incontinence. So these are real specific. When it says functional, when it says focused, it means you're just concentrating on the urinary system or the urinary incontinence. So what are some interventions that we can do for urinary incontinence? Well, general strategies for bladder health are talked about in box 14.5, and these are things: void before meals and at bedtime, drink 6 to 8 glasses of water a day, get regular exercise, practice the pelvic muscle Kegel exercises, 10 seconds tightens and 10 seconds relax. Practice the urge suppression. Avoid caffeinated beverages. Now, why is that? Because caffeine is a diuretic, and it can make you have to go to the bathroom. Maintain an ideal body weight. Avoid obesity, which is always a good thing. In every disease state, you're going to see this come up. Ensure bowel regularity and avoid constipation. Now remember, if you think about your anatomy, the bladder there is in front, but what's on the left? On yourself, on the left. Well, that's where your rectum is and your colon. So if you get constipated, it could press in on the bladder. It could press against the bladder. I've known people with diverticuli that usually occur in that left side of the colon, and the diverticuli have actually burrowed into the bladder, and then before you know it, some stool is coming out of the urine. So, these are things that we have to notice. Odors we might have to smell, but it's important for us to know, right? It's important for us to be aware that this could happen, because who would think that it would have happened? So what are some interventions? Inadequate knowledge, decreased socialization. So if a patient has urge incontinence, stress incontinence, maybe they don't want to go out and laugh. Maybe they don't, because they might accidentally have an accident. So they might start avoiding social activities because they don't want to be embarrassed. If they go out to dinner, they want to sit by the bathroom, which isn't always where people want to sit. They might want to sit by the window, have a view. So it's kind of hard when you go out with friends or family. Impaired self-concept. So adults who become incontinent may be so embarrassed that they're reluctant to tell anyone about it. Some older people do not seek help for incontinence because they think it's caused by old age and can't be corrected. Then there's a potential for skin breakdown, and that's a big problem. Urine and feces, if left in contact with the skin, may contribute to development of a rash or yeast infection, especially in persons with diabetes. Continuous moisture causes the skin to lose its oily protective barrier, and skin breakdown may follow. And the key to preventing breakdown is to keep the skin dry and free of urine or feces. Potential for urinary tract infection. So the patient who is incontinent of urine is at risk for urinary tract infection and urinary calculi. These complications are most likely to occur in patients with urine retention and in those who restrict their fluids. Go down that paragraph a little bit, and it says patients may restrict fluid intake to try to reduce the frequency of incontinence. However, concentrated urine is a risk factor for infection and calculi. So they don't drink urine. Oh boy, did I say that? There are some places that do that. They think it's healthy. But anyway, they don't drink enough fluids because they don't want to have to go to the bathroom. But then that leads to concentration of the urine, and that could lead to a urinary tract infection. So it's not a good idea. To reduce the risk of urinary tract infections, encourage the patient to empty the bladder as scheduled, provide adequate fluids, and use a strict aseptic technique during catheterization. Keep the perineal area clean and encourage the intake of 1,500 to 3,000 mLs of fluid per day unless contraindicated. In other words, if they have kidney problems or cardiac problems. Now, we're going to go on. Let's ask a question though. So what percentage of men over age 60 experience urinary incontinence? Let's think about this question. So if a man over age 60 probably has prostate problems, right? But the answer is, although urinary incontinence is twice as common among women compared with men, 17% of men over the age of 60 also have the condition. Among men who have had a radical prostatectomy, as many as 30% have some degree of incontinence. So a lot of times prostate issues is the problem with the male. So that's something to keep in mind. All right, another question. When blank mLs of urine collect in the bladder, stretch and tension receptors are stimulated, causing the bladder to contract and the internal sphincter to relax, sending a message to the brain of the need to void. So how many mLs of urine do you need to get that message to the brain? So the answer is B, 200 to 250. So the bladder contracts and the internal sphincter relaxes. A message is sent to the brain, making the person aware of the need to void. Because the act of voiding is normally voluntary, it can be delayed until an appropriate time. And the external sphincter can be relaxed, permitting urine to flow from the bladder to the outside of the body through the urethra. Okay. Now we're going to talk about bowel incontinence. So it's less common than urinary incontinence. It's believed to affect 20% of community-dwelling older persons and 50% of long-term care residents. It's a lot. So what are some common therapeutic measures? On page 229 is where I am. So first thing is enemas. Enemas may be necessary to stimulate emptying of the bowel in the patient with fecal impaction. You can disimpact a patient, but you need to be very careful because you've got that vagal nerve there that can slow the heart rate down. Removing retained stool is imperative before starting a bowel program that includes increased fiber and fluids. So fiber and fluids are going to be your secret with bowel, to get them on a regular regimen and keep them going. Now there's different types of enemas. We used to use soap sud enemas. Now they have like Ducalax type enemas. Oil retention enemas are really good because it helps kind of slip the hard stool out, makes it easier to pass. Well, I don't personally like them, but I mean, I like to use them on patients because of that oil. It makes it easier for them to pass. It's not as painful. Now, rectal tubes, you may not see those too much. We used them a lot in the ICU when we had patients that had just profuse diarrhea. And you know, diarrhea or stool incontinence can lead to urinary tract infections. So you need to keep that patient clean. And if you've got someone who's going all the time, it's hard as a nurse to take care of somebody that's going so much. So we would put rectal tubes in. And of course, they're larger than a catheter or an NG tube. They're probably the size of your little finger. And then they would be hooked up to like a urine bag, because remember, this is loose diarrhea, so it could be like in a urine bag. But it helps contain the urine and protects the skin. Also, drug therapy, laxatives and stool softeners, antidiarrheal drugs may be used for loose stools depending on the cause of the incontinence. Now, for patients with C. diff or Clostridium difficile, that's C. diff, antidiarrheal medications are contraindicated because that needs to be treated. That's an infection. It needs to be treated. Or it was caused from an infection, but it still needs to be treated with flagyl. So then there's surgical treatment. Surgical options include repair of anal muscles, implanting electrodes to stimulate and strengthen the perineal muscles, and placement of an artificial sphincter. Biofeedback for patients who are motivated and able to follow directions and whose external anal sphincter is capable of responding. So a balloon is inserted into the rectum and inflated. A manometer creates a tracing of the normal response of the sphincter to rectal pressure. So it just learns how to get the feeling back. Now, this is really important. Dietary changes, really important. So the patient can be advised to avoid foods that stimulate the anal sphincters to relax. Now, unfortunately, these include chocolate, coffee, tea, and other caffeinated beverages. Raw fruits, fruit juices, prune juice, grape juice, raw vegetables. So conversely, which means oppositely, the foods that thicken the stool as well as potentially contribute to constipation. So if you've got a patient with diarrhea, you want them to have a thickening diet. If you have someone who's constipated, you don't want them on a fiber diet. So these foods, maybe you've heard of the brat diet, which is against diarrhea. That's bananas, rice, apples, and tea. That's what we used to use. This says bananas, rice, bread, and processed foods, fried foods, potatoes. So I think the white bread and potatoes are really important. And think about that. They are kind of thickening, aren't they? We use those. They are thickening agents. Also red meat, dairy products, milk, cheese, we know is constipating, oatmeal, a diuretic effect. Alcohol and caffeine both can have a diuretic effect and contribute to dehydration and constipation. Because when you're dehydrated, less fluid, you can get constipated from that. So they just go hand in hand. A diet high in fiber will help normalize loose stools. Now, there's odor-causing foods, and those include cabbage family. We talked about that in the ostomy lecture. Cabbage family vegetables, beans, garlic, eggs, fish, and turnips are all odor-causing, gas-producing. Beans, we know, carbonated beverages, cucumbers, cabbage, broccoli, dairy products, and corn products produce gas. Okay, what are some types of fecal incontinence? Well, there's overflow incontinence, and that's caused by constipation in which the rectum is constantly distended. The fecal mass builds up until the entire colon is full. That's uncomfortable. A fecal impaction may or may not be present, but that's uncomfortable for the patient. They are uncomfortable. They may not be eating. This could be sign and symptom, right? They stop eating. They can't go to the bathroom. And when you ask them when was the last time you had your bowel movement, a very important question. The first step is to cleanse the colon. So you want to get them all cleaned out if they're constipated. Medical management of bowel overflow incontinence is concerned with immediate relief of the constipation and long-term control of the problem. Now, really important, phosphate enemas and suppositories may be ordered to empty the rectum. It's kind of like if you know a colon prep, you need that whole colon cleaned out. So it's a process. So daily enemas for 7 to 10 days are then needed to empty the entire colon. Because remember, you not only emptying the colon, but you've got the small bowel too, and that's going to produce stool. So it keeps coming down with peristalsis. So you've got days and days of stool coming out. Daily enemas for 7 to 10 days to empty the entire colon. Instead of enemas, the physician may order oral laxatives. So starting from the top, I like that because it starts from the top and then just pushes it all out. Biscadil, polyethylene glycol, or mannitol. If hard masses of stool are present, they can be softened with oil retention enemas and then removed digitally. Again, remember, be careful of that vagal nerve. Once the colon has been cleansed, regular evacuation is essential. So once you've cleaned them all out, you're starting from square one. And then you just keep them on a diet of fiber, fluids, and maybe a daily stool softener. Right? All right, so then there's also neurogenic incontinence. Many people report having a bowel movement shortly after breakfast. Bowel activity is stimulated by gastrocolic reflex. So every time you eat, you might get an urge. Some people get an urge to go to the bathroom. That's the most common time to get an urge. That and after having coffee, right? Bowel activity is stimulated by the gastrocolic colic reflex. When food enters the stomach, it stimulates peristalsis and causes the movement of the fecal mass into the rectum. Patients who are unable to voluntarily delay defecation are said to have bowel neurogenic incontinence. This occurs most often in patients with dementia. These patients may have 1 or 2 formed stools daily after meals. Good to know, good to document. If you have a patient like that, be sure you document that's what their schedule is so that the next nurse is aware that this happens. So neurogenic incontinence is treated with scheduled toileting based on the need and the time of defecation. All right, anal rectal incontinence is associated with nerve damage that causes the muscles of the pelvic floor to be weak. Rectal abnormalities may be present, including loss of anal reflex and loss of anal sphincter tone. These patients have several incontinence stools a day. What's the treatment for that? Well, anal rectal incontinence is initially treated with pelvic muscle exercises, those Kegel type of exercises, the tightening of that pelvic floor, and that you can have them concentrate on their rectal area, tighten, count to 10, relax, and count to 10. And you can have them do that several times a day, and that's a really good treatment for anal rectal incontinence. Pelvic muscle exercises. Oh, this is my favorite part. So when you're getting your history, so why are they here? Reason for seeking care. What's their bowel pattern? Now, notice this is the Bristol stool chart. This is real. Somebody really, this is probably Dr. Bristol, right? Dr. Bristol made a stool chart. And so if a patient ever says, really, or maybe a family member, what is normal? What's a normal bowel movement? Well, here you go. You got a stool chart. Type 1, hard little pieces. Type 2 is a sausage shaped, but it's lumpy. Please don't laugh at me for doing this. I kind of have to. Plus, I think it's important to know. And wait till the end. I got another one for you. So type 3 is like a sausage, but cracks on a sausage. And type 4, like a sausage or snake. It's smooth and soft. You see, now think about your anatomy. You've got the rectum, which is kind of round, right? And you've got this this is almost like the shape of your colon, isn't it? So it's backed up into the colon. And that skinny one there, type 4, it's like a sausage or a snake. It's so smooth and it's gone up high in the colon. I'm getting way too excited about this. And it just slips right out and slips right into the toilet. Type 5, soft blobs with clear-cut edges. Type 6, fluffy pieces with ridged edges. Type 7, watery, no solid pieces. Now I didn't include type 8. It's called the ghost. And what happens there is you go to the bathroom and you turn around and look at it. Now you got to admit, you guys do that, right? You look at what you just did because you want to see how it is. And this, you want to check your patients too. But what if they have a ghost where it just disappeared? It was so heavy and big, it just went down the toilet. It's called the ghost. So that's funny. I think that's funny. All right, so back to the book. So take their, what's their normal bowel pattern? When do they go? Go after a breakfast? They go after at dinner time? Some people go in the mid-afternoon, maybe after their coffee. And using that Bristol stool scale, you want to know the characteristic of and the shape of their stool. Are they constipated or have diarrhea? But now what's really bad is if they have a tarry stool. What does that mean? A tarry is used to describe stools that are shiny, sticky, and black. That means there's been blood, old blood. Abnormal colors like black, red, green, and white all mean a problem. White could be something like a bowel problem. But tarry stool, it's very thick and sticky. Melena tends to be black or burgundy in appearance, and it's very sticky also, and that is usually blood in the stool. Now maybe they had an ulcer, because a black, sticky, maroon, melena type stool means a bleeding higher up in the stomach because it's old, and that's why it's black. If it was bright red, that means it's a lower bleed. Okay, so on the other page, on page 232, is your axial Bristol stool chart. I did not make that up. Past history, any neurological conditions, stroke or spinal cord injuries, dementia, that's important. Do they use laxatives or enemas? I mean, some people need to use one every day. They use a laxative every day. It's called melanosis cola. I won't say it. Okay. So, you know, they can buy these stool softeners, laxatives over the counter, so they may not even think to mention it to you, so be sure that you ask them specifically about it. Review of systems, inspect and palpate the abdomen for distension, and auscultate for bowel sounds. You want to do a functional assessment, their habits, their diet, their fluid intake, their exercise. You know, exercise is very good for bowels. Did they travel recently? You know, that really used to be asked every time you go to the doctor. Have you had any travel recently? Because you might have brought something back. So recent travel to other countries may be significant because they acquired intestinal infection. So some interventions for bowel incontinence, loss of bowel control. So continue monitoring is an essential part of the nurse's role. Documentation, always good. When was their last bowel movement? What did it look like? What color was it? If they need to have a bowel program established, you need to take them to the bathroom for defecation, usually about 30 minutes after eating. If they have a suppository or an enema, administer that as ordered, and what was the result. So be sure you always document the result of any intervention that you do. So explain normal bowel physiology to the patient. So always explain why you're doing what you're doing. And how they should eat. Be sure they eat vegetables, fruits, high fiber, lots of fluids, and exercise is important. Now, potential for skin breakdown. So after each incontinent stool, cleanse the perianal area thoroughly and apply protective ointments. Protect their skin per your agency policy or doctor's order if you ordered something. Incontinence undergarments may be needed to prevent soiling and embarrassment. Be sure to check frequently so the stool does not remain in contact with the skin. That reminds me of something funny. So I just babysat, you know, my grandbaby and still in diapers, right? So I forget to check for stool, and heck, it doesn't bother her. And then there I'd find every 2-3 hours, and I'd change her diaper, and there might be a stool in there. I didn't even know it was there. Been a while since I had a baby, I guess. So, impaired self-concept. It can be devastating to the patient. So just be sure that you don't act, irritated or make them feel embarrassed about what happened, because it's really very devastating. All right. Sounds good. Thank you.